Ladies and gentlemen, boys and girls, welcome to yet another interesting episode, the Editor's Insights of the IJA podcast. In this episode, we will be covering the February 2024 issue, few relevant articles, and what our senior editors think about the topics. I'm Murli, your host, and joining me this evening is the President-elect of Indian Society of Anesthesiologists, Dr. Bala Venkat, a senior teacher, professor of anesthesia in JSS Medical College, with a vast experience of more than 35 years in teaching, Professor Gurudutt, and the professor and head of the department of Kanyakumari Government Medical College, Nagercoil, in Tamil Nadu, Professor Edward Johnson. And joining us, of course, is Professor Rakesh Garg, who is editor-in-chief of Indian Journal of Anesthesia. So to start with, we are going to talk about something related to regional anesthesia, and who else can be with us to discuss this better than Dr. Bala Venkat. This issue of February 2024 had two articles featuring rectus sheath blocks. One is a systematic review and meta-analysis, and another was a clinical communication. So we will discuss something related to facial plane blocks and understand more about what's happening in this world. Dr. Bala Venkat, welcome to the IJA podcast.
Good evening, Dr. Murli. Thank you so much to you for this innovative concept of the IJA podcast. And thanks to Dr. Rakesh Garg, the editor-in-chief, for making this happen.
Thank you, sir. Thank you. So to talk about facial plane blocks, as we are all aware, this is something which is new in the field of regional anesthesia, which was not there a few decades ago. And the popularity is increasing day by day. Could you just tell us a little bit about the different types of facial plane blocks that are currently in clinical practice and what kind of indications are they being used for?
At the advent of ultrasound, we had new vistas of treating pain. One, the surgical pain, and second is postoperative pain. And the surgical pain, we started using limb-specific block, the brachial block for the upper limb, the lumbar and the sacral plexus block for the lower limb, where you identified the nerve and injected the drug close to the nerve to producing profound analgesia and surgical anesthesia. But the same thing could not be true for the thorax and the abdomen and to an extent pelvis, because we didn't have specific nerves supplying like what we had it for the upper and lower limb. Of course, we had the neuraxial block and the paravertebral block, but it had its own issues and complications and inability to do it. So when the new blocks came in, where the drug was deposited between two fascia, and the facial conduit helped the drug to seep in to the nerves, and this resulted in good analgesia. So for example, if we do a spine surgery and postoperative pain relief for spine procedures, the erector spinae block seemed to have really helped people in the immediate postoperative period in decreasing opioid consumption. So all that we needed to do was to place the drug between the transverse process and the erector spinae muscle. And here the drug spread across the path of least resistance, and it blocked several levels of the dorsal rami of the intercostals. So when you talk about intercostal block, if you go and specifically individually block intercostals, it's going to be inconvenient, tedious, whereas the same thing is accomplished by giving an erector spinae block. So the interfacial plane block seems to be an excellent component of multimodal analgesia for thorax and abdomen, and that's why the PEG1 block, the PEG2 block, the serratus anterior plane block, the parasternal block, the currently new block, the external oblique intercostal plane block for liver surgeries, which actually initially started with a TAB block. That was the first, probably the most well-versed and used interfacial plane block. From there, we digressed into several facial plane blocks. Primarily, these facial plane blocks are given in the deep fascia. So we have the superficial fascia and the deep fascia, and this drug is given in the deep fascia.
Thanks, sir. Now, looking at the kind of research that is coming out, there are of course a lot of debates that do happen whether these facial plane blocks are really effective. So there's always a camp on the other side which debates and kind of challenges the efficacy of these blocks. So what is your take on the research that is coming out regarding the efficacy and safety of these facial plane blocks when compared to our traditional approaches?
Yeah. So as I said, the big difference between the traditional approach and the interfacial plane block is the traditional approach uses a small volume of local anesthetic solution to produce a dense block when it is placed in perineurally. But when you deal with the interfacial plane block, it's a larger volume, but with lesser concentration that is given. But since it is of late, it has been proved that it seems to be of real good component of multimodal analgesia and has a good opioid sparing effect on the immediate postoperative period. I think it has got a definitive role to play in the immediate postoperative period, more in analgesia rather than anesthesia. And I think what will define it more is we need to place the drug, as I said, in the deep fascia. But now what we understand is there are multiple layers in the deep fascia. So we need to have a technology which helps us to decipher the layers of the deep fascia. So one should be, the equipment should become more competent enough to distinguish in the multiple layers of deep fascia and to know where to place the drug and where the drug spread is going to be more universal is number one. Then number two, I think there's a lot of research that's going into microanatomy with the evolution of a lot of people spending time with electron microscope and seeing this facial planes. The microanatomy of the region becomes more clearer and it gives an answer to several of our questions. And the third important thing in the technology which is developing now is the optical projection tomography, which is actually a 3D imaging of the small biological tissues. I think all these put together is going to revolutionize the use of interfacial plane block so that it is more effective and it's placed in the right plane.
Thanks a lot for the insight, sir. Now, again, talking about the future, of course, we are seeing, enhanced recovery protocols coming into play, especially with all kinds of surgeries. Now, do you feel that, as you mentioned about the technology, the microanatomy, and the other newer technologies which are coming in for facial plane blocks, do you think that we'll be using more of these facial plane blocks for with ERAS protocols in the future?
I 100% feel so. I'm very convinced that they form an important component of enhanced recovery. And my personal opinion is we have used extensively in spine surgery in our institution, and we feel so, especially with major spine procedures, with the large involvement of the spinal segments, the recovery has been excellent. And I completely believe in opioid sparing and the consequences of using large amount of opioids. For example, in our scoliosis surgery, we use a 4-quadrant ESP now. Whenever we use a 4-quadrant ESP, the postoperative requirement of fentanyl has become very, very less. And the ability of the patient to breathe well and the acceptance of food earlier or palpable changes that we notice. So I firmly believe that there is a role of interfacial plane block in ERAS protocol.
Now, coming to teaching, sir, these are blocks, as you said, as somebody as a regional anesthesia fellow, when he undergoes training, there are blocks which are taught, which are essential blocks or plan A blocks. Then we get the other blocks. Coming to the facial plane blocks, where do you, put them in the hierarchy of blocks that a trainee should learn? considering that you probably have the highest intake of regional anesthesia fellowship trainees in the country, or probably I would even dare to say, probably in the world. So you have been training people, especially in regional anesthesia for more than a decade. So where would you put these facial plane blocks, and what are the tips that you would probably give a trainee if they were to kind of learn facial plane blocks, and how different are they when compared to a traditional perineural block?
It's definitely challenging, especially when you start training anesthesiologists who come for a RA training. First is getting the sonoanatomy and image optimization, and then the needling. The advantage of going towards a specific targeted nerve is very easy because that particular structure is not moving. It's very stable. And so the needle goes towards it. In a breathing patient, for example, if I wanted my fellow to give a tap block, it's a huge challenge because now the patient is breathing, and with every movement of the diaphragm that's coming in, there is a movement. So eventually what you see is the tip of the needle. It has to be between the two fascias, but with the movement, you see the drug going into the muscle plane. So it is definitely a challenge in some of the interfacial plane blocks. So it needs much clear training. And initially, first, we need to do it in a patient who's paralyzed, and then show them what happens, the initial, the spatial separation, what happens, and then how the drug spreads. So once you train them like that, then you can do it on a patient who is breathing. But also, for example, when you deal with a simple, what we think it's a simple block like an erector spinae block, everything changes when you do a thoracic level ESP. They need to really know whether it's the transverse process or it is the rib, because it completely, the whole thing changes, and it needs definite insights to be given. And I think it's easy to tell them, but it definitely is not as simple as blocking a single nerve. But having said this, the youngsters are sharp. It's all the willingness of the mentors to tutor them in a way that makes sure that nothing is impossible. And I'm very confident of the Indian youth who seem to be harnessing all that is good in the globe to give the patient the best.
Thank you, sir. Thanks for the very optimistic view about our next generation coming up, and thanks for those wise words. And thank you for joining us for this podcast, sir. It was great to have you and your insights on the facial plane blocks. Thank you.
Thank you very much. Thanks, Dr. Murli.
Next, we have another stalwart, a person who is well known to postgraduates across the country. It's Professor Gurudutt. Welcome to the podcast, sir.
Thank you. Thank you, Dr. Murli. Thank you so much.
Thanks for joining us, sir. Now, considering the rich experience of teaching that you have and the passionate teacher that you are, I've chosen a topic for you, which again is something very dear to the heart. And also, I'm sure many postgraduates listening to this podcast will be looking forward to. So this is the topic is based on an article which appeared this month in February 2024. Which was an observational exploratory study on acute kidney injury following emergency laparotomy. So regarding perioperative kidney injury, what would you consider are the main risk factors that anesthetists should be aware of?
So actually, there are a lot of risk factors, and these risk factors can be actually classified as the patient-centered risk factors, surgical-centered risk factors, and also the drugs what we use, many times nephrotoxic drugs and medications, they also can produce the acute kidney injury. So basically, the patient risk factors are, the age of the patient, especially geriatric patients with more than 65 years or even 70 years, they are highly prone for developing acute kidney injury. So the other thing is the male sex. Of course, there is slight controversy between whether male sex are more prone or female sex, but of late it has been found that other than the cardiac surgery, majority of the surgeries, non-cardiac surgery, it's the males patients are more at risk of developing acute kidney injury. The other risk factors are, patient having a comorbid conditions, especially if the patient is already having an acute or a chronic kidney disease. And the other things are like patient having a morbidly obese patients, like patient with more than 40 kg per meter square of the body mass index. And again, the other comorbid conditions like patients with hypertension, patients with respiratory diseases, and the patients with diabetes mellitus, especially the insulin-dependent diabetes mellitus. So these are some of the patient risk factors. Whereas coming to the surgical risk factors, the cardiac surgery especially is more prone for, these patients are more prone for developing acute kidney injury. What they have found is CABG, the incidence is much less when compared to the valvular heart surgeries, especially the aortic valvular heart surgery. The incidence of aortic valvular surgery with acute kidney injury is almost 30 to 35%. It's quite a bit. And basically why these cardiac surgery patients are more prone for acute kidney injury is because one thing they say that it may be because of the cardiopulmonary bypass. The CPB by itself, is pro-inflammatory. Plus the RBCs while passing through all these, tubings and all, they may get damaged, and once they get damaged, they may release, oxidative inflammatory process, and they may by themselves may produce oxidative stress. The third thing is the hemoglobin that is released can actually block the renal tubules and can produce acute kidney injury. The other problems like, non-pulsatile flow during the CPB also can induce acute kidney injury. That has been thought about. And the other thing is the hypoperfusion that can occur because of the hypotension during cardiac surgery. So the other than cardiac surgery, the vascular surgeries, especially the endovascular surgeries, especially where the aortic cross clamping is being done, whether it is above the renal artery or infrarenal, still both can induce hypoperfusion of the kidney, and then that can induce, acute kidney injury. So other than these, the non-cardiac, non-vascular surgeries, like especially intra-abdominal surgeries, and especially the emergency intra-abdominal surgeries, again, these patients are highly prone for acute kidney injury, especially because of intra-abdominal hypertension or intra-abdominal increase in their intra-abdominal pressures. Though, of course, when you say intra-abdominal pressure increase, laparoscopic surgery is because, the intra-abdominal pressure rise is not for a long period. It is not much associated with acute kidney injury. So, these are some of the, surgical, insults that can produce the problem. But whatever it may be, it is always, intraoperatively the hypotension that occur. So what has been found is if the mean arterial pressure is reduced to less than 55 millimeters of mercury for more than 10 minutes, or mean arterial pressure reduction is less than 60 millimeters of mercury for more than 20 millimeters, in these major surgeries, the patients are prone for, acute kidney injury. So the other important thing here is the, the nephrotoxins. They also can produce, the acute kidney injury, especially radio contrast dyes. They are, notorious to produce acute kidney injury. The ARBs and AC inhibitors and certain antibiotics like aminoglycosides, all these drugs also can produce acute kidney injury. So patients who are on these things are definitely be highly prone to develop acute kidney injury, and we are supposed to be very careful when managing such patients, and that too when they are posted for a major non-cardiac, non-vascular or cardiac and vascular surgeries.
Now, regarding the fluid management, now whenever we go to a conference and come back, many a times we come back confused because there will be one talk which says that we should give liberal fluids, that another speaker will come and say, no, you have to restrict the fluids. Now, coming to the choice of fluids, I'm sure many youngsters are confused as to what should they give. Should they give a balanced salt solution? Should they be giving, saline? And how much of fluid should they be giving? What are they targeting? So in your view, what is the best fluid strategy in a high risk patient? In the risk factors that you mentioned, that should be done to prevent perioperative kidney injury.
Now, what has been found by many of the studies that have been done is still the balanced salt solution is probably the best intravenous intraoperative fluid that can be used. Especially, it is said that the saline should be avoided, especially when these patients are posted for major surgeries and a lot of fluid infusions have to be given. Why saline? Though we call it as 0.9% as the normal saline, and many people say it as an abnormal saline. Because why abnormal saline is, 0.9% has got, it's isotonic, because as far as sodium is concerned, it is isotonic. But when chloride is considered, it is really quite a bit of chloride is there, hyperchloremic, because 154 milliequivalents of sodium and 154 milliequivalents of chloride is there. Normal chloride levels are about 100 to 110. Because when we use large quantities of saline in major surgeries, and when we are producing hyperchloremia for the patient, this hyperchloremia can produce a lot of problems, especially to the kidney. So one problem is that the chloride itself can produce afferent arteriolar constriction of the kidney and then can produce hypoperfusion of the kidney and can produce kidney damage. The other thing that has been said is chloride by itself can directly damage the renal tubules and can produce a acute kidney injury. The other problem is when so much of chlorides have been infused. So what will happen is the kidney will try to excrete bicarbonate. So once bicarbonate is excreted, the patient will go in for the metabolic acidosis. So once the patient goes for metabolic acidosis, that itself will bring out a lot of potassium from inside the cells, hyperkalemia. What has been found is when compared to giving balanced salt solutions and saline in large quantities, saline itself produces more hyperkalemia than the balanced salt solutions because the balanced salt solutions contain potassium by themselves. The other problem is this normal anionic gap, though it's a normal anionic gap metabolic acidosis, its effect on the heart, it can produce depression of the heart. Because of that, again, hypotension, hypoperfusion of the kidney. So because of all these, saline may not be an ideal choice of fluid for intraoperative fluid for patients who are at risk of kidney injury. So better to go for balanced salt solutions. Especially balanced salt solution, one can go in for either ringer lactate or plasma light. Even plasma light is equally effective when compared to ringer lactate. The advantage of ringer lactate is the cost. So coming to the colloids. So crystalloids are the best. We all know that for whatever, whether it is in the ICU or for intraoperatively. So because especially what has been found with HITA starch, it can by itself can induce acute kidney injury because of this osmosis that produces. It can produce renal, the epithelium, swelling of the renal tubules and can produce blockade of the renal tubules and can produce acute kidney injury. So of course, gelatins can produce a lot of allergic reactions. And among the colloids, maybe, the albumin, because it has been studied in septicemic patients. It has been found to be equally effective when compared to ringer lactate or saline. But the problem of albumin is the cost. So with all this, I would say that balanced salt solutions are the best intraoperative fluids.
Thank you. Now, if you were to have a patient who is at a risk of kidney injury and you have, of course, chosen the balanced salt solution, are there any other agents that you would think of giving, any other drugs which are nephroprotective, as we can call them? It could be either, vasopressors trying to keep the pressures up. It could be diuretics sometimes, which are again used, or any other agents. What would your choice be, sir?
So ideally, I was talking to you about the blood pressures because the blood pressures are very, very important. So one has to maintain in a non-hypertensive patient a mean arterial pressure of above 70 millimeters of mercury in these high-risk patients. And in hypertensive patients, it is always better to maintain about 80 to 85 millimeters of mercury of mean arterial pressure. So, but this should be ideally done in the intraoperative period by using fluids. So, of course, we know that how to use fluids. We can always talk about that, especially when we use dynamic monitoring and know whether the patient is, can or require a fluid resuscitation, then we can keep on giving fluids. But definitely, always the fluids cannot maintain the blood pressures. Only in such situations where even after maintaining a euvolemic status, still the patient is hypotensive, then one can go for vasopressors. But there are inotropes. The basic problem with any vasopressors is all of them can produce afferent arteriolar constriction of the kidney vessels. So one has to be very careful in using vasopressors. Unless they are really required, they should not be used. So probably the better vasopressors present maybe norepinephrine. Noradrenaline may be the ideal choice. Other than that, angiotensin 2, I don't know whether it is available in India or not, because when I was, searching for which better vasopressor one can use. So it has also been said that angiotensin 2 has been advocated as an alternative for noradrenaline, because the angiotensin 2 produces increase in the resistance of the efferent arteriole. So once the efferent arteriolar resistance is increased, the glomerular perfusion pressure will increase and there will be a better perfusion. So and about the diuretics, definitely diuretics have no role in management or in prevention of acute kidney injury. They can be used only when there is hypervolemia. So by chance, the patient has developed hypervolemia, maybe he has already had a chronic kidney disease. In such situations, probably diuretics may help. So other than that, the mannitol, which was supposed to be a very good renoprotective agent, has got, of course, no role nowadays. And dopamine, of course, in our days, when I was a student, even I was asked about the renoprotective effect of dopamine, and there was a short notes also for me. So we used to then, during those days, we used to say dopamine is an ideal choice. But of course, now it can produce more injury rather than any advantage. But of late, dexmedetomidine has been found to have a lot of renoprotective effects. And especially it has been, a lot of studies have been done in cardiac surgeries. When dexmedetomidine has been used intraoperatively and preoperatively, it has been found to reduce the incidence of acute kidney injury. So probably dexmedetomidine can be used in all these patients, provided you maintain the pressures.
Excellent, sir. Thanks a lot. It was actually like reading an editorial on acute kidney injury. I'm sure the listeners also will agree to this. Thanks a lot for joining us and sharing your insights. Of course, the introduction of POCUS, ultrasound being now more widely available in many centers, and using POCUS, we'll be able to assess the volume better, and the VEXA scanning, which is being used in many centers, again, will probably prevent the perioperative kidney injury occurring in many patients. So thanks a lot once again for joining, Professor. Thank you.
Thank you.
The next guest we have on our podcast today is Professor Edward Johnson, and we shall be discussing a very important topic with him, which is post-spinal hypotension, mainly in the obstetric population. So welcome to the podcast, Dr. Edward.
Yes, sir.
So, Dr. Edward, coming to a very important question, what do you make of the recent studies on spinal anesthesia-induced hypotension in a cesarean section population? Because this is a very commonly performed operation, and many anesthetists would want to hear what is latest when it comes to studies on this.
So, the recently published systemic review and meta-analysis in the Cochrane database, I think it's the year 2017, regarding the techniques that prevents the hypotension after spinal anesthesia. The author concluded that they have tried many methods, that is pharmacological and non-pharmacological methods. Pharmacological methods like ephedrine, phenylephrine, non-ranitidine, and non-pharmacological method, table tilt, lower leg compression, and they have come to the conclusion that none of the single technique is useful to reduce the occurrence of post-operative hypotension, that is post-spinal hypotension in cesarean section. Recently, they have tried DIVA, that is double infusion vasopressor automated. It is a loop system. They have tried with phenylephrine and ephedrine. I think that is going to be giving a promising feature in the reduction of the spinal hypertension after cesarean section.
Now, what about the mechanisms? Now, whatever we read during our postgraduate days, when it comes to hypotension after spinal anesthesia, is it still the same, or is there anything new that is with regards to our understanding?
All of us know there is a sympathetic block below the level of spinal anesthesia results in vasodilatation and reduce venous return and reduce the cardiac output. That is the preload theory. It stands good in nowadays also. But there is one afterload theory is also there. There is a reduction in the systemic vascular resistance is one of the reasons for the hypotension. In obstetric population, in addition to that, we have a supine hypotension syndrome of pregnancy. That is the main reason for the hypotension after spinal anesthesia in cesarean section.
And what about the specific patient characteristics? Now we get a variety of patients, with high BMI, low BMI, tall patients, patients with comorbidities. It could be diabetes or pregnancy-induced hypertension. So, what kind of role do these play in the onset and severity of spinal hypertension?
If you take up the age, the compensating mechanism for spinal anesthesia is generally more effective in younger age groups. In elderly age groups, the age-related changes like alteration in systolic function and diastolic relaxation can aggravate the decrease in the cardiac output in the case of spinal hypotension. Moreover, the exaggerated bradycardia is more common in young individuals. Regarding the BMI, the influence of BMI in spinal anesthesia is still controversial. The spinal anesthesia can be significantly prolonged in obese patients, although the ED, if you think the ED 50 of local anesthetic for obese patient is same as the non-obese patient. Even though the height of spinal anesthesia is higher in the high BMI patients. This may be due to the per segment reduction in the CSF, due to the fat in the epidural space or in the dilatation of the epidural veins in the epidural space that compresses the spinal canal, and per segment spinal volume is reduced. So the level of spinal anesthesia is higher in the obese patients. If we take any patients for comorbidities, we always wish to give a spinal anesthesia for high-risk patients with comorbidity by adding dexmedetomidine or fentanyl to the bupivacaine to reduce the dose of local anesthetics and also to increase the duration of anesthesia. In that cases, if you reduce the local anesthetic dose, there is definitely a hemodynamic stability will be there. So these are the spinal anesthesia related hypotension related to age, BMI, and comorbidities.
And what if we have a patient where we have, as you said, we have tried various things. It could be ephedrine, phenylephrine, noradrenaline. Now, if the patient is not responding to the initial treatment, especially when a cesarean section is happening, what would your thinking be? What is your plan A, plan B, plan C? Is there anything that you would be thinking at this time when patient is not responding?
It often happens. Mainly in obese patients, it often happens. They will be not responding to the initial treatment like your vasopressors or your anticholinergic atropine. It will not respond. The patient will go for a severe bradycardia, severe hypotension. In that place, first line of drug should be adrenaline in the bolus of 50 mg or 100 mg because it is a pre-cardiac arrest condition. We have to go for a prevention of cardiac arrest by giving adrenaline. And especially in the obese patient, you have to be very careful regarding the volume status. You have to preload the patient. You have to go for a pelvic wedge, and you can start a preoperative noradrenaline infusion also in obese patients. They are more prone for a severe hypotension. We have to be careful.
I'm sure the field is evolving ever so, especially when it comes to understanding. And again, as I mentioned earlier, the introduction of POCUS also in the obstetric population might make a huge difference going forward. Thank you for joining Dr. Edward for this podcast and throwing light on this important topic of spinal-induced hypertension. Thank you very much.
Thank you, Murli. Thank you, Rakesh.
Now,
Thank you,
last we have the editor-in-chief of Indian Journal of Anaesthesia, Professor Rakesh Garg, who's been a part of our podcast ever since we started. And welcome to the podcast, Dr. Rakesh.
Thank you so much, Dr. Moti. Thank you so much for taking the show forward.
Thank you. Now, as it's tradition, we would like to know secrets about IJA when we talk to you. So today, I would like to actually ask you a little bit more about behind the scenes of how the peer review process happens, how the reviewers are working in the background, the editors are actually working in the background, because there is tremendous amount of work which goes behind. So we want to know the secrets behind what happens when it comes to review.
I think, Dr. Murli, it's not a secret, it's an open book. And many people around the globe are working in this arena of publication. And I know it's not a secret, it's an open, transparent. Actually, first of all, thank you so much to all my editorial board members, editors, reviewers, and authors. I think the growth of a journal and delivery of a good article is the combined effort of each one of us. Though sometimes I may lead the show, but having a robust team with me, which always should be acknowledged, they do a lot of hard work. So if somebody submits a paper, at this juncture, I will say that when you go on shopping of something, your title, your name should impress somebody. Same, I think that's a secret, that if your title, your abstract is good, it makes me read the whole article, at least. But if I think that the article, the abstract is having no novelty, or it is already published in the past, it will deter me to read the whole article. I think that's the secret. So don't expect each one of us, when IJA is getting a huge number of submissions every month, we may not be able to read all the articles. So be your title, abstract very succinct, showing some novelty, showing some good methodology into it. So I think that's the secret number one, open secret now.
No, the secret I wanted to know is now the numbers. How many submissions are you getting every month?
I think the number is increasing. It fluctuates, and we are reaching a huge number of submissions every month. And I will put it other way rather than giving actual numbers, because that may vary. We have the rejection rate of 70 to 80%. That's a huge number. So we are publishing around 20 manuscripts, and 80% 90% rejection rate is being achieved, which is always good for any good journal. A global journal like Indian Journal of Anaesthesia.
So now, once I submit, or anybody submits an article and you feel it is worth publishing it, what happens to this article? Where does it go?
So I have a team of my editors with it. Usually the first screening usually goes from my office, myself. I screens it and take some decision. And then some of the articles are distributed or assigned, in fact, to the editors based on their area. For example, if somebody is coming from cardiac anesthesia, I will give it to my editors who have a vast experience in cardiac anesthesia. Same is for airway, same is for regional anesthesia, so that they can take a very balanced decision based on the reviewer remarks and on their own experience and knowledge. And then they check it. It requires sometimes technical modification. So I will again urge authors that IJA has published instruction to authors. If you don't follow it, it gives a bad image that probably I'll say that we are not so serious about it. At least you should be following the norms, the requirements of the journal. And this is applicable for all journals. And then when they have technically corrected version is received from authors. So if you prevent this step, your article will be at least ahead by at least week to 10 days. So I'm just showing you that you can get a faster decision, because sometimes we have taken a decision within a week also, and sometimes it's take 3 months. So I think it's a combined effort. And then it go to reviewers, editors, again take their opinion, a combined decision for acceptance, rejection, or revision. Majority of time, it will be either rejection or revision. Acceptance at first go is usually not there. So because we want to refine the article to the international standards, so the experts put their inputs. I will again urge authors that don't mind. The experts are giving opinion. So take it with open heart and open hand, because many people are working to make your article more refined. It is good. I agree. You have done a hard work. I fully agree. But it can be made a little better. So accept those comments given by the expert persons. And then it comes back to me for a final decision. And I usually honor the decision of our experts, our editors, and then I take a combined decision based on the requirement of the journal, based on the similar articles, because sometimes I may have accepted similar articles in the recent month which is going to be published. So probably if it's almost similar, then it may be a deterrent factor to take it forward.
And how many hours do you see every editor or reviewer spending on a daily basis? Because to get a ballpark picture of how things are, I think we need some number here, because many people will not know the amount of work that goes behind the scenes.
So I think more the hours, more the merrier for the journal. I spend usually around 4 to 5 hours a day on an average. All my editors are spending at least 6 to 8 hours every week. This is minimum. All my editors are doing this much of hard work, because the process is not only for commenting, it goes proofreading, technical check, final issue formation, and then grammatical, scientific. There are so many other things which also goes, in fact, giving comments. Because when you see the final issues, it requires 4 or 5 proofreading also, in which we do a technical, scientific, and formatting check to maintain the uniformity. So most of my editors are spending almost 6 to 8 hours every week. So anybody who wants to join this editorial pool, just remember that this much time you're supposed to spend for the journal. And in fact, for any journal across the world, they expect this much time if you really want to contribute something and if you really want to learn something out of it. I'm really learning from IJA.
Thank you. I'm sure the authors also will appreciate, considering the amount of work that goes into writing an article, the amount of work put into conducting a study. It might be years, sometimes even we have seen studies which take place over decades. So I'm sure the effort that goes in from the other side, from the editor side, also is very much appreciated. But more importantly, I would like to say, and I'm sure you'll agree, that we need to get these articles reaching more people. And I appreciate your initiative on infographics and the amount of good work that's happening on that front, because I'm sure the articles are reaching much more when it comes to more people than what it was earlier. So
absolutely. I think at this juncture, sorry, I'm interrupting you, Dr. Murli. Just, I think one of the basic, you can say the goal of a publication is that it should be beneficial to the community at large. So when we publish an article, we have used the participants as our, you can sometimes we can use a word that they have really helped us to conduct a research on those participants, of our study. Let it go to the whole population across the globe so that everybody is benefiting. So please share your articles to your colleagues, to your social medias, to your groups, so that people gets benefited. They can change the clinical practice and give benefit to the patients.
Thanks a lot for this wonderful message. Thanks for joining us, Dr. Rakesh, and again sharing some insights. We will bother you with more secrets, trying to learn more secrets in the next show. Thank you very much.
Absolutely. Absolutely. Thank you so much. Thanks.
So to end the podcast, again, I would like to thank all the listeners for sharing their valuable time, whether you are taking your evening walk or you're commuting to work or back home. You've been listening to this podcast, or even at home if you're listening to it. Thanks for joining and sharing your time with us. And we look forward to bringing you more exciting episodes with more knowledge and insights in the coming months. Thank you for joining.